We're so happy that all of you are here. Thank you for joining us. French Hospital is, so good at providing cardiac care, and you will be assured of that after you hear from the amazing physicians and directors that are here running the cath lab, running the cardiac care center here at French Hospital. We're so happy that you're here. My name is Tessa Espinoza. I am the vice president of the foundation here, chief philanthropy officer for the foundation. The foundation is very, very excited to continue to offer educational opportunities like this to our community so that you can learn even more about how wonderful French Hospital is, and also all that we offer just for your own sake and for your neighbors, for your family, for your friends, for our community. We're really grateful to share all that we do with you and to be able to answer some important questions today. So this is the second in a series. This series is called What's Up, Doc, as you all know. The first one was on primary care on the Central Coast, and I'm very glad to see some returning faces, some folks here that came to the first session and enjoyed it, apparently, and now you're back again, so thank you. Obviously, this session is on cardiac care. We have another one teed up around orthopedic surgery for all of you pickleball players out there. So we are excited to continue to showcase all the many services and all the many things that we do well here at French Hospital, and of course the clinicians and the folks that are so well trained in providing expert care to each of us. So wanted to introduce myself quickly, and then would like to, are we next teeing up the reflection? So we have a tradition here at French Hospital where, and actually within our entire organization, Common Spirit Health, of opening up our meetings with a reflection, just to sort of ground us in why we gather together. And so we are going to play a grateful patient story for you, a little video. This is a patient that received excellent cardiac care here at French Hospital, and we think that it would sort of warm us up to listen to John Summer share his story about getting cardiac care here at French. So let's play that now.
We first became involved actively with French Hospital in a community level through my wife, Liz. Liz has always been a huge supporter of healthcare in any of the communities that we've lived in. Very, very important to us. My experience with care at French Hospital has been extraordinary. I've been in here for a number of different reasons, as has my wife, Liz Summer, and our children. And every time, without exception, we've had the most wonderful care. I'd actually gone into Dr. Adam Niku, who's my cardiologist, for a regular annual test. And we did the stress test thing. And apparently I was overstressed in the stress test. And so I needed to have a follow-up procedure, which is an angio, just to find out whether there's some blockage in there that was causing the reactions that I had during the stress test. Gosh, I said, that was quick. Did you put a stent in me? Because I'd had a stent before. I thought that was going to be the beginning and end of whatever procedure I might have, is another stent. And they said, no. I said, there's really nothing we can do for you. And I said, what do you mean? He said, no, there's nothing we can do for you here today. You're going to have some more extensive surgery. That meant open heart surgery, and ultimately I had to have a bypass. So what I had started off as just a general procedure that I was somewhat familiar with from having had it done before, turned out to be an extended stay at French Hospital. I stayed here for 2, maybe 3 days, felt fantastic. They had me all wired up, and once they were able to take off all the wires and tubes and everything, they released me, and here I am a little more than a year later, talking about an experience that for many people would be filled with trauma. And I must say, my experience was anything but traumatic, other than the surprise of not having planned for it. You look back and you go, yeah, that was bad, but it was so wonderful that this was all here for me and my family and my friends and my community. that they could offer the care that I needed at the time that I needed it most. We're grateful to have a facility of this quality in our community.
I think it's great to hear directly from the patients, right? So it's a powerful message. I'd like to now introduce the CEO of French Hospital, and also Marion, and also AG, Sue Anderson.
Thank you, Tessa, and I'm going to update you on a few things happening around the hospital, and luckily I have a few minutes to do that while we're waiting for our physicians to come. We've almost got them all, 2 out of 3. So exciting things. So a couple of things happening at French. One is tomorrow the American Hospital Association is coming here, and the reason that they're coming here to survey our hospital is that Common Spirit Health, our parent organization, we have 142 faith-based nonprofit hospitals all across this country. They applied for a Quest for Quality Award with the American Hospital Association. And the American Hospital Association said, pick one hospital that we should go to see what you do for quality in across your organization. And so they picked French Hospital. And one of the reasons they did that was because French Hospital has a 5-star rating out of 5 stars from Medicare, CMS, and they have 26 straight A's from the Leapfrog Group, who is a safety and quality rating organization for hospitals. We are the only one in California with those credentials, and one of only 8 across the United States with those credentials. And so, yeah, so it's really... So I feel like all of us that live in this community should feel so proud that we have a quality hospital here in our community, and you're going to hear some of why we're a quality hospital pretty soon here, because it takes a village, and it takes recruiting quality physicians to the area and maintaining stable staff. We have a lot of people here who celebrated, in fact, at our employee awards, we had celebrations of 35, 40, and 45 years of employees that have been here that long. And a lot of it's the culture here, and it's a great place to stay. We all believe in this hospital. So a couple of other exciting things that are on the horizon as we're talking about cardiac. We will be opening a new cath lab in about a month. Yeah, God willing. But we have brand new equipment going in, so state-of-the-art cath lab to go along with our other cath lab. And then we're working on, hopefully next week, our public announcement is going to go out about a new cancer center that we're partnering with physicians on and opening off of Tank Farm Road and Broad. And it's a very exciting project. It's going to be one location that's going to have all the oncologists. It's going to have our Hearst Cancer Resource Center. It's going to have radiation oncology, infusion center, MRI, CT. It will have a surgery center. General surgeons will be in the building. Urologists will be in the building, maybe some GIs. And really, hopefully, we're excited to have the Hearst Cancer Resource Center there, because it will kind of be a one-stop shop and a place where if you're newly diagnosed, we'll be there for you, and you can go right into the Hearst Cancer Resource Center and get learn about the resources that we have available to help you. So that's an exciting project that we're doing. And then the other project is, of course, the Beyond Health, the tower. I know we've been talking about that for a number of years, but the exciting part is next week, next Thursday, the architects who drew the original plans and everything are coming here to work with all of us on updating the plans. They need to be updated to the 2022 code within the state of California, and that's what we're working on right now. It's a multi-million-dollar project just to get everything updated, but that's really kicking off the project again, and we're hopeful that we will be having a lot of great announcements in the next few months about that project. So a lot of really exciting things happening here. We're here to take care of our community, and that's what we want to do. We want to be able to continue to provide top quality services for our community. So with that, I think I will turn it over to Christy Dixon, our director of our cath labs. And she's going to lead this panel, and I'm sure we'll have our third participant here any minute.
Yeah, running across the parking lot.
So literally any minute. Anyway, thank you all for coming too. We really appreciate the support from the community. I know I was going to try and turn this one on, but I don't know where.
I think, yeah,
We hit the red.
we'll run it back down here to Dr. Perry.
Oh, I'm on.
Oh,
Okay,
yeah.
I'm loud anyway.
So everybody has their own.
There you go. Well, we'll start off with some introductions, and then we'll add in Dr. Thompson when he arrives. My name's Christy Dixon. I'm the Director of Cardiovascular Services here at French. I have been a nurse for 20 years, all of which has been in cardiac care. I think I became interested in nursing and cardiac when my dad underwent open heart surgery when he was 48 years old, and I think maybe I was a freshman in high school, and we went up to New York City because I'm from the East Coast, and they put us up in a apartment building across, I believe it was New York Presbyterian, where he had his surgery, and he underwent valve surgery, and they had a PA that actually brought out his valve, this crusty looking valve in a specimen cup that we got to see in the middle of the surgery, and he's 75 and still doing great with that valve. So I think that's how I got on this track, and then I've spent my time working in the ICU. I took care of post open heart surgery patients, and then I moved to the cardiac cath lab as a nurse in 2010, and have worked there and been really passionate about that ever since. And then over time, I got suckered into management and now this director role that I'm actually very much enjoying. And I lead a really great team, and I work with really fantastic docs, so I feel very fortunate and happy to be here at French. So I think this What's Up Doc is pretty timely for American Heart Month in February. We'll introduce one of our CT surgeons here at French. This is Dr. Paul Perry, and you can maybe tell a little bit about how you came to get here.
Thanks. Paul Perry. I'm a cardiac and thoracic surgeon, but these days I'm mostly cardiac. I've been doing CT surgery for a little over 8 years now, and about 5.5 of those here at French Hospital. And in our practice, we also operate at Marion. I joined a group that been in the area for a long time. I think it's going on maybe 40 years now, and I believe I'm maybe the 5th hire. So it's been the first two guys started it, got the program going. One left, and then this Dr. Scow was here with the 3 current guys that I work with now for many, many years. Then he retired a few years back and was actually still taking some call and assisting in things when I started 5.5 years ago. So I was the first hire in 20 years anyway.
And then this is Dr. Jason Turner, and he's probably, Dr. Thompson, when he gets here, is probably the most recent to join French, but he's been a fantastic addition to our hospital and really is growing vascular surgery program here at French.
Yeah. So good evening. Sorry for my tardiness. The vascular surgery gods do not do not give us time off for anything, including lectures. But again, Jason Turner. Very happy to be a part of the French team. I actually started out wanting to be a cardiothoracic surgeon. That's the whole reason I went to med school. I had actually got talked out of cardiothoracic surgery when I was young and naive, and it was just a naive ambition. And then I actually had a career, ended up owning an insurance brokerage, and actually got really lucky in the Southern California market and retired and said, what do I want to do with my life? And some of the most fulfilling moments were the time that my family and I spent in Mexico working with a nonprofit organization called Corazon, and building houses for homeless down there, or families that didn't have homes, and giving back to a community. And so one day my wife and I were driving back from the Florida Keys, where we were looking at buying some rental properties when vacation rental by owner was actually all spelled out.com. And we were deciding what to do, and I looked at her and I said, what would you say if I became a cardiothoracic surgeon? She said, well, that sounds fun. Little did she know, as Paul will attest, the training is pretty arduous to get there. So as I sort of rapidly went through that sequence of educational, milestones that you have to go through. One of the things that I realized real early on when I had amazing cardiothoracic mentors was that the world of cardiothoracic surgery was training. And even the world that Paul grew up in versus where the cardiothoracic surgeons are who are graduating today, it's very different. We're doing a lot of things minimally invasively that were, sort of the core tenets of cardiothoracic surgery. And although we will always need amazing people like Dr. Perry, it's a changing landscape. And I recognize that. And so in order to try and get ahead of that, I wanted to have the endovascular, the minimally invasive skills that are required in a lot of the structural heart stuff that these guys are pioneering today. And so I chose to do a vascular surgery training pathway, ultimately with the goal to become a cardiothoracic surgeon fellow. But in that process, I fell in love with my patient population, and I fell in love with the longitudinal relationship that I got with my patients. Because unlike cardiothoracic surgeons, not all of them, those patients are typically managed by cardiologists. In my field, I typically manage those patients from the medical standpoint as well as the surgical standpoint, because really the only person between me and my patients is really a primary care provider. So I don't know what our audience is today. You guys might have spoken on in the beginning. That was sort of my question to you guys is, who are we talking to today? Just so we can sort of tailor what we're talking about to, are you guys in the medical field? Are you guys all community members? How many people are in the medical field in some way? Okay, so community members, perfect. This helps us to know what lexicon and nomenclature to use. That way you better understand what we have to say and can be excited about these things that we're passionate about. So yeah, that's a long-winded introduction, but I fell in love with vascular surgery and I fell in love with the advancements that were available. And I thought for sure I'd spend my career in a large tertiary academic center in a metropolitan area, a 1,000-bed hospital. And then I realized my roots of wanting to be that shaman in a community and wanting to take care of people. And so I work for Associated Surgeons, a longtime group here that's been here for 35 years. You guys may know them as the Hayashi group. And I found my shamans. I found the Hayashis, and I knew that those were the birds that I wanted to flock together with. And we quickly became best friends, and the rest is history. And so I bring, sort of that academic vascular level care to our simple community, but plan on being here for the next lifetime.
I guess we can circle back, Dr. Perry.
Dr. Thompson's trying to get in the building.
Oh, it's locked out. Oh, wait, top-notch security. What made you choose CT surgery?
Oh,
and then how did you end up down here in Pismo? Because you came to us from UC Davis.
Yeah. I don't really know how I got to CT surgery for sure, to tell you the truth. I've been asked that question many times. Like a lot of people, when I was younger, a close family member, my grandfather, required open heart coronary bypass surgery, and that was an important event for me. And that was right at the transition when I was about to start medical school. So I was really interested in what was going on, and I was so impressed in how it helped him. And I was very close with him, and I was close during that recovery process. And he had a great outcome. I think he was in his early 70s when he had that operation, and he was with us until his early 90s. And so that always stuck with me. I started medical school, and I throughout my entirety of my training, I tried to keep an open mind of where my interests might lie, and what I might enjoy, what I could be good at, what I'm not so good at. So every rotation and every specialty that I experienced, I went into it like this: is this something I could do? Could I be an OBGYN? Could I be an ICU doctor? Thompson?
Or a cardiologist.
Yeah, cardiologist. But I liked surgery, and I felt I ultimately made the decision that surgery was for me, and I still had that interest in heart and vascular. The time I was doing my training, pretty much everybody, when you finished medical school, you went into general surgery training first. So you learn how to do trauma, take out an appendix, gallbladders, a 5-year training program to become a board-certified general surgeon. And then when you're done with that, if you want to do other things like plastic surgery or cardiac or different things, you can go get additional training in that. So as that process went on, I developed a love for all things chest, heart, lungs, vascular surgery. I was really actually torn between becoming a vascular surgeon a lot of things Dr. Turner was alluding to with the merging of different worlds and technologies and where things were going. I thought about that too. But ultimately, I really liked operating in the chest, and I felt like that was something I made that decision. And then even once you're in cardiothoracic surgery, now more and more, some people specialize more in doing lung care because lung cancer and esophageal cancer have become much more complex than they used to be. So you need people that are really, really good at that. And cardiac surgery has just become more complicated as well. As we're doing bigger operations on sicker people, and it takes, basically you just need more expertise. And so as time went on, and I was doing my cardiothoracic training at UC Davis, I was only there, it's a 2-year program to start with. I was there for about 6 months when they offered me a job to stay there afterwards. And so I kind of knew what track I was on, and I was liked the idea of being in academics for a while, and it became pretty clear I was probably going to gravitate more towards being a heart guy. And so that finished, and I kind of had my job plan there, and I told them, I said, well, this is great, I love working with you guys, I want to be here, but let me leave for a little while and come back so that I can learn some things you haven't taught me and just get a little, do some different things and come back with my new job. And so I ended up going to Cedars-Sinai doing, at the time at Davis, they really had a need for advanced heart failure, so people are working towards a heart transplant or having mechanical hearts, in addition to all the other stuff we were doing, and I really liked that type of work. So I ended up at Cedars-Sinai. None of this was planned, right? So that's what I'm trying to get at here. I just kind of, seeing what worked for me and what was good. But I ended up at Cedars-Sinai. That year I probably did more heart transplants than anybody else in the world. It's the busiest heart transplant center, certainly in North America, and I was kind of doing all of them. And a lot of everything, which was an amazing experience. Got back to Davis, was able to just kind of hit the ground running because I knew it was just a good setup to get going right away. And it was really great, and I enjoyed my job there, and I enjoyed the academics and the teaching, but ultimately, I felt like that probably wasn't a forever plan for me. I always, when I started all this, when I went into general surgery in the beginning, I envisioned myself as a community general surgeon, kind of like Dr. Turner was referring to. I wanted to work in a town like this one and be close with the community and provide really high-level care. And so ultimately, I kind of had a decision to make whether I was going on a path where I was really going to be an academic and kind of be part of that University of California system and just be part of that for a long time, or maybe pivot. And so I decided to pivot, and then this job was just a real 1 in a million type of setup and amazing people I could work with, and so it was kind of a tough decision, but ultimately absolutely the right one. And all that being said, I really feel like I'm exactly where I'm supposed to be, and it was, I think what got me there was just sort of keeping an open mind and talking to people and that could mentor me and just ultimately finding my path by what made the most sense and what worked best for me. So
now you're in the
Dr.
hot
Thompson.
seat.
What's the question?
All right, we're starting off with some self-introductions and then talking about what made you choose your specialty. Dr. Thompson's kind of our latest recruit to the Central Coast. Obviously, there's some very highly talented, great physicians here in our little community, and so we're pretty fortunate, and we're really happy that he's joined our team.
Yeah, so what got me here was the weather. Man, you guys fooled me. No, so I'm from Bakersfield, California, and yeah, from the it's pretty much the same, yeah. I mean, I'm not going to go back all the way, but basically got into cardiology. Really liked interventional cardiology. That's a term for basically a very fancy plumber. We fix blockages. That's kind of what we do, similar to Dr. Turner, but mostly in the heart. And was very fortunate to have some very good training. Most of that was all the interventional training was done at Scripps, which is sort of in the interventional world, sort of Cedars and Scripps sort of compete with all of that as far as doing the PCI, the stents, the TAVR, the different kind of valves we put in without opening the chest. And then knew that I wanted to come back to the central part of California. Wasn't sure where, and ended up at Cottage for a few years, and then got recruited back to my hometown, back to Bakersfield, and helped kind of build the cardiovascular program there. And the whole time was sort of talking to the group here who I've known since my training days, and they finally pulled me over this last summer. So specifically what I do, to get kind of specific and maybe a little too technical, stents, you've heard of stents. Those are little metal tubes we put in arteries and open up blockages. That's our bread and butter as interventional cardiologists. I enjoy doing the really complex kind of stents where an artery will sort of branch in two branches or potentially have been blocked for many, many years, and we try to reopen it. In addition to all the stent work, there's kind of a newer subset or becoming its own field, I guess, in interventional cardiology, and that's something called structural heart or structural interventions. And those started off with TAVR, so that's transcatheter aortic valve replacement. So it's a way to replace the aortic valve usually through the groin artery without opening the chest, which has been a game changer for a lot of people who may be a little bit higher risk for having standard surgical aortic valve replacement. I've also been trained to do something called MitraClip, which is a way to repair the mitral valve, also through the same sort of mechanism, using the vein to get to the heart. And if you've all heard of Watchman, that's another kind of procedure within the structural heart realm. It's a little umbrella device that we seal off a little blind pouch of the heart that tends to make a lot of clot when someone's in AFib. So it's an alternative to blood thinners. And then there's some pretty basic or standard congenital stuff that I deal with. Holes in the heart, PFOs, ASDs. And I fix those too. So, yeah, that's me.
Okay.
At least part of me.
I guess just kind of sorry.
What's a hole in the heart?
Yeah, so I hate that term actually, but everyone uses it, so I kind of use it too. It's usually what we're dealing with is the two upper chambers of the heart, the atria. There's a wall that separates those chambers. When you're in the womb, there's actually a little channel called a PFO that allows blood to kind of go back and forth between those two channels. When you take your first breath, the wall or the two layers kind of seal up, so blood can't get over from the right to the left side of the heart. But in up to 30% of patients, we think that there's a PFO still there. So a third of us are walking around with a PFO, which is not a big deal. I mean, it's not a big deal unless you have a stroke and the neurologist can't tell us why you had a stroke. There's no plaque buildup, there's no clot coming from AFib. That's called a cryptogenic stroke, in which case now there's 5 trials that tell us we should close that PFO, that little channel, which it's a device that we put up from the groin. It's the same day discharge kind of thing. An ASD is an actual defect. That actually is a hole in the wall there. And those sometimes can be closed the same way. Yeah.
What age are you doing those? Are you doing any pediatric cases?
I don't know. Yeah, 18 and over. Yeah.
Yeah, fortunately, baby or child heart problems are relatively rare. And a lot of them are identified pretty early on and corrected when they're very small. And then the others that, develop that need correction in children and stuff, there's a few children's heart centers that do such a good job with that sort of thing. Actually, a lot of people have offered that we maybe have too many of those hospitals. You should maybe have fewer that do more kids rather than, but they do an excellent job. In this state, we have 3 or 4 excellent children's hospitals for heart care. So.
Any other questions before we move on? Okay. Dr. Turner, can you tell us about an innovative practice or maybe some services that you offer that you do here at French and how they help your patients? Yeah. We know you do vascular, but tell us more.
Yeah, vascular is from the head to the toe, right? So, I think probably, akin to what you're already hearing from Dr. Perry and Dr. Thompson, medicine is quickly evolving, and vascular surgery is certainly on the forefront of these evolutions. And a big part of how we're evolving is trying to do our good old tried and true procedures and remedies, but trying to do them in a minimally invasive way, right? So anytime we can make the cut smaller or to do something without a cut, often we view that as a win. There has to be a balance. We have to make sure that that repair is as durable or close to as durable as the way we used to do it open. And so a lot of what you're going to hear today of us bragging about the future and the next steps and the things that we're bringing is going to talk a lot about the minimally invasive things that we're doing. Everything from Dr. Perry's more minimally invasive techniques to do open heart surgery to our minimally invasive ways to get blood where blood was struggling to get before, or to fix aneurysms, because those are the two things in vascular surgery that we really deal with. If you break it down into broad categories, is you have atherosclerotic disease, which is blocking up a blood vessel, or you have a blood vessel that is becoming aneurysmal, right? For whatever reason, it is degenerating. It is a balloon at a birthday party that's getting too big, and we're worried it's going to pop, right? So I'm probably most passionate, and what Christy gets probably the most calls from me about are our patients who were working for limb salvage. And what I mean by limb salvage is they're at threat of losing one of their limbs, most often their lower extremities. When I first got here in our county, in just our local hospitals, we were doing well over 20 amputations of the lower extremity a month, right? Now I think we've got that number down to 2 or 3. So a drastic decrease in the number of amputations we're doing. Part of that is right from the beginning with the primary care doctors doing early outreach and finding the pathologies and treating the pathologies that cause it, which some of our main things are diabetes and tobacco abuse and hypertension and the other predisposing factors to cardiovascular disease. So we're doing a little bit better job of reaching out to the primary care physicians and our emergency medicine colleagues to catch these maladies a little early and to intervene before the cat is out of the bag and we've lost the limb. Worked very closely with the podiatrist, and we've developed a bit of a limb salvage team. And part of that is right here at French and focused here because we have a hybrid operating theater, which is the only hybrid operating theater in the county. In fact, even beyond the county, we're actually supporting our colleagues down at Marion Hospital as well as part of the Dignity system and making sure that their patients who have some of these issues are still well taken care of too. And that's actually, there's further advancing the care in the community is expanding the access to a vascular surgeon. I'm the only board certified vascular surgeon in the county. My senior partners, the Hayashis, have done some bread and butter vascular surgery in the community for about 30, 35 years. But we've had some pretty major gaps where we haven't had a vascular surgeon who's just dedicated just to vascular surgery. So I think limb salvage is where you'll get me to be most excited and animated to talk about. So we do things from bypass, where we'll take a vein or other conduit and we will bypass blockages in the leg surgically. But more and more now we're doing this also minimally invasively using Dr. Thompson's tools of wires, catheters, balloons, sometimes even stents to get down just like we do in the heart. I was actually trained in limb salvage by an interventional cardiologist who had turned his whole entire career into just focusing on the legs. So taking all their techniques and figuring out how to revascularize those really tiny blood vessels of the calf and feet, just like the heart, and get blood flow where it wasn't, so that instead of an amputation, they get new blood flow and maybe a toe amputation or debridement or podiatric care, and are still walking around our community and not facing all the morbidities that an amputation ultimately leads to. That's probably the most exciting thing for me.
I can attest to that patient population really increasing because I get calls from Dr. Turner on the weekends and at night and halfway through the day. Can he get into a cath lab? He's got a patient that he needs to get in. And he's definitely passionate about those patients. He was leaving one day and we asked what he was doing, and he was actually going to one of his patients' homes who wasn't able to make it into the office to follow up with them. So will you just kind of dovetail to give them a little more explanation on what the hybrid suite is and how that's utilized? And actually all 3 of our docs really utilize this special cath lab that we have here that can be used for many things.
Yeah. I think that's one of the things I hope the subtle takeaways that's unspoken that you take away from is that there's 3 unique specialties here. And if you go into many other communities, those are specialties that are at war with each other for dollars. And then one of the really neat things here is, one, the people on the ground and our individual take to it, but then also our leadership, right, who has put us together and supported us in a way, and our community that has supported us in a way where we can really just do what we're passionate about and take care of people. And I think there's some selection bias here, and that there's providers here who are putting their community first over the dollar, because you have to work here. You're going to make less than the big city, and it's going to cost you more. But the neat thing is the amount of collaboration. There's so much crossover from what you're hearing us talk about. And that crossover starts a lot in the hybrid operating theater. So it's an operating room that is an open surgical suite, right? Just as Dr. Perry can do an open heart bypass in that room. He can put a patient on pump, right, and do a complete heart bypass or a valve repair. And at the same time, we can bring Dr. Thompson's patient in there, and he can do a coronary angioplasty in there under live x-ray. We call that fluoroscopy. And I can bring the patient in right after him and do a hybrid procedure where I'm cutting, making an incision, but then using wires, catheters, balloons, and other devices to insert a graft or to restore blood flow to a part of the body, all in this one theater. And again, French is the only one in the county, the only hospital that has that capability. And they're multi-million-dollar rooms. So they're big investments. And beyond just the room, you can spend the multi-million dollars. I worked for the VA, and I watched the VA do this, and they opened this beautiful room, and they were proud, and all the mucky mucks were touting their horns about it. And then it opened, and nothing happened, because it takes tons of resources just to support a room like that. If you think about it, you have an operating room staff, but then you have a cath lab staff, right? You may have a perfusionist in the room, right? You have anesthesia needs their own space to operate within that room, because it's not just a cath lab where you're doing a patient under conscious sedation. You're actually putting them to sleep most often for our bigger cases and things like that. So it's a multidisciplinary space where we all get to work and take care of our patients, but it's really where it's sort of the heart of a cardiovascular center. It's where a lot of the magic happens.
That's a special room for us too, because I think it enables us to do a lot more high-risk procedures where, maybe things that you wouldn't do if you weren't able to quickly convert to an open surgery if need be. And so we've certainly done that in there as well. I think probably this might be a good time, since we're talking about special techniques and procedure offerings. If Dr. Perry wants to share, I think he's got some visual on something he's passionate about.
So I'm no good without pictures as a surgeon. Patients come to see me in the office, and by the time they leave, they're all these things I've drawn out for them, and they're taking pictures of stuff I drew, and so I didn't really know how to do this without some audio-visual help. But the background of this, in terms of what I think I've been able to help contribute to the community, and a lot of where our specialty is going is most heart problems for adults are going to be either coronary disease or valve problems. That's the majority of it. Or a combination of those two things. And we do other stuff too. We take care of aneurysms and weak hearts with different assist devices and some rhythm disturbances, but most of it's valves and coronaries. And like I said, I joined a practice that was very well established, been offering very high level quality services for decades. But there were a couple gaps. And one of the gaps was in mitral valve care. So the mitral valve, there's four chambers, four valves in our heart. Separate those chambers, keep all the blood going the right direction. And the mitral valve is kind of a special one. It sits on the left side of the heart. After the blood has gone through the lungs and become oxygenated, there's a reservoir for it. Then it passes through the mitral valve before it goes into the big pumping chamber that pushes it out to the rest of our body. It goes through one last valve on its way out to the body. And all those valves are keeping blood from going backwards. So the mitral valve is seeing a tremendous amount of pressure from that pumping chamber, keeping the blood from moving backwards right back to the lungs. The most common valve to have a problem for most people is the aortic valve. So that's where we were talking about TAVR earlier, and we have these excellent devices now, transcatheter aortic valve replacements, where we can do more and more without having to do open heart surgery. Dr. Thompson and I did one just earlier this morning. We do actually probably several a week in our community. But the mitral valve is still largely surgical. That's the second most problematic valve for people. And then the story goes on. So, the plot thickens. Mitral valves often, in certain patients, can be rebuilt and made to work again. So the other valves, especially the aortic valve, if it has a problem, it's usually coming out. We're putting in a prosthetic. And the prosthetics we have work really, really well. For most people, that's all they're going to need. But for the mitral valve, the prosthetics we have don't tend to last as long, or they get a mechanical valve, which is the type of prosthetic that will last a long time, but they're committed to blood thinners for the rest of their life. And a lot of people who have mitral valve problems are on the younger side. I'll see patients in their 30s and 40s. So, it's either rebuilding their valve and taking what they have and making it work right, which will probably serve them well for the rest of their life, or committing them to be on a strong blood thinner for the rest of their life, depending on the surgical techniques that we use. So it's pretty important stuff. And it's a complex valve. There's a lot that goes into it. And what most practices have done, what we've done here, is you kind of pick one person to sort of focus on that valve. So if you have a practice of 3, 4, or 5 surgeons or more, it's not unusual to have one guy that kind of does most of these, just so you can get more familiarity with it and do more of it. And so that's kind of what we've developed here. When I came, that was identified as something we needed some help with, and fortunately, as part of my experience and journey that I described earlier, I've gotten exposure to really good mitral valve care and worked with a lot of surgeons who are very good at it. So just kind of hard to talk about that a little bit of anatomy, but when we're looking at a mitral valve, this is kind of what we call the surgeon's view. So this is sort of what I'm seeing when I'm looking down in there, in a cartoonish way, of course. We're not seeing these other valves, but this is the tricuspid valve that's on the other side of the heart. This is the aortic valve that sits right above it. But this is the mitral valve, and it's simplified and everything. There's basically 2 big leaflets that come together and touch each other. The other valves all have three leaflets, so it's special in that way with the 2, a lot of other things. Here's that big pumping chamber I was talking about. But it's got these, what we call chordal attachments. There's these little muscles that it inserts on, and then the other end of that rope is on the free edge of the leaflet. So when that ventricle fills, this would be filling with blood while the heart's relaxed, and then pushes it out to the entirety of the body. The job of this valve is to snap shut and keep that blood from going backwards into this chamber. And those cords, are kind of like a rope on a sail. They kind of help hold things together. And there's a bunch of things that make this work. And so with all those different things that make it work, there's a lot of ways they can fail. There's lots of different parts of it that can fail. And a big part of our job, and working with Dr. Thompson, the other cardiologists, figuring out what exactly is going on here and what we can do about it. So I just kind of circled a bunch of things that can go wrong. You have torn cords here. You can have problems with the leaflet itself. In the gaps between the little sub-leaflets, there can be issues. Sometimes the edges don't come together well. All this inserts around kind of a skeleton within the heart, a fibrous, what we call a fibrous ring that can get stretched out. It's almost universally stretched out. So if it gets stretched out, those leaflets can't come together. All these different things can come into play. And then ultimately, though, what's happening, instead of these 2 leaflets coapting nice to one another and keeping the blood moving where it's supposed to go, there's leak. So this is the heart. After it's been filled, it's pumping now. It's supposed to be going all the way out to the body. But leaky valve, a lot of it's going backwards. And that just leads to all sorts of problems. So what I wanted to talk about is what do we do about that? So when a lot of heart surgery was just getting off the ground, people invented prosthetic valves, right? They invented mechanical valves that could, basically recreate what nature intended. You cut out what's there and then sew in this prosthetic. And this very famous surgeon, he's still alive, Dr. Carpentier in France, he was actually he invented prosthetic valves and came out with his own inventions of different types of prosthetics and stuff. But after doing all that work and already being famous for that, he realized that he wasn't satisfied, and some patients were still having problems with the prosthetics. The prosthetics themselves were leading to issues, especially when you're committed to being on blood thinners and things like that. So in the 80s, he basically invented how to rebuild these valves and take what somebody has and make it work again. So he developed the initial techniques for that. And the classic teachings, a lot of them started with him and were developed by more and more people. And it kind of caught more traction in the 90s. And that's kind of when it sort of hit prime time. but it really relied on a lot of cutting out of stuff. So in most people, the problem would be kind of this part of the leaflet. Again, this is sort of what the surgeon's looking at when you're in there in the heart. Usually it's a problem in this lower part of the leaflet, what we call P2. So sort of the classic repair, the one we're all taught early on, if you have good teachers, is to kind of cut that out and sew it back together. Just cut out the bad part and sew it back together, and then usually put in some sort of stabilizing ring. And this is what we call a partial ring, that just sort of, it doesn't go around the entirety of the annulus, which is the hinge point of the valve, but goes through most of it. So that's kind of a classic thing. And that's how I was taught to do them, and used it for many years, and fairly happy with it. But as time has gone on, people have been refining and adding more techniques and doing different things. And this is just one type of repair. There's lots of other things, but this is probably the most common thing where most people are getting. To add to that, another thing that's important in this discussion is sometimes what some people do is just sew the middle parts of the two leaflets together. That's called an alfieri stitch or an edge to edge. And that's important, especially for what Dr. Thompson is a specialist in, because they've developed techniques to recreate this where you just kind of pinch together the middle. Because again, a lot of it's a problem in this bottom part. You just pinch together the middle with a catheter, where you don't even have to do it with open heart surgery. So that's an important thing in the modern minimally invasive techniques. But these are kind of what was there. But when you're done with it, though, you end up with a smaller overall area for the blood to move through. So as I kept learning about more and more mitral techniques, and when I first came 5.5 years ago, this was sort of my default way of operating. But as I was kind of paying more and more attention to what other people were doing and different techniques, I started adopting more and more what we call a chordal valve respecting, or sort of leaving more leaflet and not cutting out as much stuff, and kind of changing the way we put it all back together at the end. So with that repair I just showed you, I'm going to show you a picture, a video here. This is a good repair. So this is an echo that's been done, and it shows the valve working. So here's where the blood is starting here, it's coming down here and getting pumped out. Can I show that again? But what I want you to notice about it is you can only see one of those leaflets really moving. It's kind of what I call like a toilet bowl lid. It's like, so the bottom one where they've cut out the leaflet and put that ring in there is really stiff. And then the other leaflet is flopping up and down on it. And that's okay. I mean, this is a good result. That's a good repair. People would be satisfied with that. But the way I'm thinking, and probably what Dr. Thompson thinks too when he sees some of these down the roads, I think it's more likely to lead to problems down the road. And so a lot of people have been questioning, is there a better way to do this? Are there other techniques? And so that's where I've kind of come to adopt what we call a respect repair. The other one is a resect, where you cut out part of it. This is more of a respect. So I'm leaving more of the leaflet in there, leaving what's there, and then finding ways to tuck everything back to where it should be. And a lot of that includes, like I mentioned, a lot of these are related to these little cords tearing, or just, here's again that same part of the leaflet that's out, and just kind of tucking that down and anchoring it back down to a different part of the heart. It's called neocords. And so about 3.5 years ago, I had been taught to do that. I used it sometimes for certain things. But about 3.5 years ago, I really transitioned to trying to do this for more and more of the valves. And I haven't looked back. I've just been so happy with what it's resulted for these valve problems. And the other thing I've adopted is that ring that was there. Again, classically, it was about a 270 or 300 degree ring. I went back to doing a complete ring. Now, the reasons I'm doing these is, one, I think it's better to get closer to what nature intended. But two, I think this gives us more opportunities, again, transitioning to what Dr. Thompson specializes in, is giving people more options for the future. So when you repair somebody's valve, if you do a good job, you typically expect it to work really, really well for the rest of their life. But even in like the biggest centers, the Mayo Clinics, Cleveland Clinics, the best surgeons in the world, there's still about a 5 to 10% failure rate over like 20 years. So when a lot of these people are young, 30s and 40s, and get these things done, or even if they're older, you want them to have, you want to really just want them to have one heart surgery for their life. And I myself have reoperated on many patients who had that resect technique done at other hospitals, and then they come to me and their valve is failing, and then we have to go in and reoperate on them. So I think by leaving more leaflet there and adding this ring, it gives us more opportunity for future technologies to avoid redo open heart surgery in the future. Plus, I just think it's better for the heart. So here's some videos I just show both these at the same time. So this is after I repaired it. This is a leaky valve. So none of that color should be there. That's a before. And then this is, let's see if it'll work again. Let me go back. The one on the right is the after. But I want you to notice to see how both those leaflets are, now they're moving and actually working compared to the toilet lid repair. So this is after I fixed it. And see how everything is moving, and both those leaves, and they're really touching each other a lot. And so I think there's just so many advantages to this. So I'm just going to move on. And a lot of those are, what comes next. And another thing to mention is that ring that I talked about that you put in there to kind of stabilize everything that goes around the outside of it. When you do the resect repair, you usually have to use a much smaller ring and bring everything down and make it small. With valves, you want the valve to be as big as possible. So by doing that chordal technique and leaving a lot of leaflet, I put much bigger rings, and basically people end up with a much bigger valve, which is also an advantage. But moving forward to the future, it gives us an opportunity to do a lot of these emerging technologies, things that we do at French and will be doing as they come along. It allows us to do them. If you've cut out a lot of leaflet and you've only put in a partial ring, you've really limited that person's options in the future if they have a problem. Again, that's going to be a minority of people, hopefully less than 10%. But if you are in that unfortunate less than 10%, the way we're doing them now, it puts all the options on the table. We have these transcatheter techniques to clip together those two leaflets because we've left some leaflet there to bring together. We have ways of bringing in an entire prosthetic valve across the ring that we've put there. When I used to use the partial ring, there's no landing zone, but now by adding 3 or 4 stitches and doing a complete ring, Dr. Thompson can come in there and land a prosthetic stent valve in that space. And it just gives us more to work with. So that's what I've been really excited about. I mean, even with all the training and teaching and the thing that's supposed to be great, people are still innovating and do different things. And then I feel like I'm a little bit ahead of the curve with this in terms of how I'm thinking about rings and leaving more leaflet and stuff just for these emerging technologies, because I feel like sometimes people that do a lot of this work, it's like, oh, I fixed the valve and it's going to be great. It's a little bit of chest thumping and ego. But the reality is, even the best surgeons in the world, there's going to be a small but real failure rate. And so I think it's important to give that patient every opportunity for all the things that are coming down the pipeline. And so that's been really good. And then we're just trying to do them through smaller and smaller incisions all the time. We've been able to make it less incision on the chest and do different approaches to the chest to accomplish this stuff. And that's basically kind of put you in the weeds with all that, but I think it really does a big advantage for people, especially again when you're on the younger side and you want something, you just kind of want that to be it for your life and be able to not have to worry about it again. You have a question?
With all these different things that that's out there, how do you train yourself to get all that stuff done?
Well, I mean, you have to have good mentoring and training to start. You have to have a good foundation to start with. And then, a lot of things at this point, I would say with surgery it's not like we're completely reinventing the wheel. We're just sort of tweaking the spokes a little bit. It's kind of taking what you already know and building on it to do something a little bit better. So for instance, we started a minimally invasive atrial fibrillation program a few years back where sometimes the EP physicians are a little limited in what they can do for an ablation. So in these really extreme cases, we can help them out by going in and doing a surgical ablation. So some of that can be done with open heart surgery, and I certainly do that for people that have AFib that are there for open heart surgery, usually for a valve or something else. But they came out with some new equipment and a new technique where we could just make a small incision at the very bottom of the sternum, kind of where the ribs come together, and go in with a video camera under the heart and do a big ablation. Well, that's like a whole new surgery that I was never taught to do in itself, but I was very comfortable getting to the heart from this little space because sometimes we need to do that for other reasons. So you kind of take what you know and your comfort with the anatomy and just your prior experiences and you add to it, and then we've been able to have this really great surgical ablation program. So yeah, it's a good question. Some of it's just, we go away. I listen to a lot of webinars. I go to meetings. You talk to other surgeons. You go visit somebody. You watch them operate. Anytime I'm thinking about taking on something new, it almost always means a visit to some expert somewhere in the country and hanging out with them for a little bit and just picking their brain and watching what they do and then deciding if that's something that we can replicate.
I think that's probably a pretty good point. None of this is done in a vacuum. They've got so many resources and great people that have mentored and that they've trained with outside of the area that it's not uncommon to see them pick up the phone and call and, hey, what do you think of this? Or take a look at these images. What would you do here? And then, in-house here, we have very multidisciplinary cardiac cath conferences that involve the surgeons and the cardiologists where they'll review higher risk cases or somebody with challenging anatomy and really think and talk through, well, what if we do this? Yeah, well, maybe that's not the best thing for this patient, what about this? And so so that's a really neat thing to see.
I want to add to that a little bit. I didn't really talk about it earlier, but one of the things that really got me interested in this world was the collaboration, the multidisciplinary collaboration. I think we've been kind of hitting on that a lot, but in surgery in particular, a lot of times it's kind of siloed and you just sort of do your little thing and that works fine. But in heart care, we really need to work together and we do work together really, really well. And that's something I've always appreciated about it. Really all aspects of it. We have a weekly meeting. A lot of it's coronaries and valves. The same thing happens with people that have failing hearts and need transplants and all that's. It's always very collaborative and it's a team-based thing. We rope in the ICU docs, other specialties as needed. But I've always really appreciated that cardiac care is kind of a team sport, and we do a great job with that here. We do as good a job as anybody.
Go ahead.
Yeah. Dr. Turner, you mentioned that the primary care doctor is the one person between you and the patients that you see. Is it primary care and cardiac doctor between you and the patient? Well,
they're often a little bit different problems. He's dealing with most of the blood vessels kind of outside the heart. Like basically cardiac would be the heart and just until the vessels go off to the brain, just kind of right all in the chest. Everything past that falls more under the realm of vascular surgery. And a lot of those problems are going to be like limbs and abdominal aortas and things like that. So often the primary care doctors will directly reach out to the vascular surgeon. But no, for me, almost 100% of the patients I'm seeing have already been evaluated by a cardiologist. The pathway is usually primary care to cardiology.
Okay, that's what I was asking.
And then even from cardiology, which is usually like a diagnostic cardiologist, they'll see a specialist like Dr. Thompson who does procedural stuff. And then usually we're working together to kind of figure out, is this something we tackle with surgery or other hybrid type of procedures?
Yeah, my thinking was the pathway is always through a primary care doctor. And in your case, it's direct. In your case, there's another guy.
Yeah.
Unless you land yourself in the emergency room for some reason, in which case, I'm not suggesting you do that. I'm saying if you came in with something emergently happening, obviously this gets fast-tracked a bit. Yeah, no, I'm not suggesting it. Dr. Thompson, do you want to talk a little bit about what we do with our heart attack patients? Just for all of you, if you don't know, we really are the cardiac center for the county. So we get patients transferred to us from Adventist and up from AG. We're the STEMI receiving center. That means if you're acutely having a heart attack and you've got a blood vessel blocked, we have a 24/7 team on call, 365 days a year, ready to be in-house within 30 minutes to open up your blood vessel. So we'll let Dr. Thompson talk a little bit about that and kind of how quickly we assess patients and get them into the lab. And
before we do that, just to kind of close the loop on the mitral valve. So a lot of these patients who have mitral valve regurgitation, or a fair amount I should say, are kind of high risk for surgery. They may have already had some surgery and they have a sternotomy, or they're 80 or 90 years old. They're getting symptomatic, they're getting heart failure, all this stuff. So we do have this thing called a MitraClip, which that image, the top left image, well, actually both are sort of describing. It looks like a little tiny clothespin. And basically one arm grabs the anterior leaflet and the other arm grabs the posterior leaflet. And we kind of just cinch it together and we close that gap so the blood can't go back the wrong way. We actually do that. It's a catheter-based approach. We go from the vein, we put a catheter about the size of my pinky up into the heart, cross over from the right upper chamber to left upper chamber, and make that our catheter kind of articulate or look down at the mitral valve and deliver our clips through that. We can deliver up, I've put in 3 clips at one time. If it's usually 1 or 2, but we get a really good result most of the time. It looks great, and patients go home the next day. It seems like every patient, but the last three patients I think have been 90 or over. So we're talking about folks who are very active, but they're not going to be in the operating room because they're just not a candidate for surgery at 90 years old. So it's been a game changer for folks who just can't do the surgical approach. And this is not in any way antagonistic towards surgical mitral valve. In fact, CMS, we have to play together because CMS requires that we do at least 20 repairs per year. So if he's not doing repairs, I don't get to do my MitraClip. So the rising tide kind of lifts up both, all boats.
This has actually been a huge accomplishment for our program in our community in the last few years. So when I first came, the volume was much less. As we really built up our surgical mitral valve program and able to recruit excellent providers like Dr. Thompson, we realized this is something we can do and we should be doing. And this is not offered at most communities of this size. And the only way you can have it is by showing CMS and showing the powers that be that you just have a high-level surgical cardiology valve program with all the right people and all the right pieces working together. And the way they do that now is a lot of it's volume. You have to show that you're doing enough of this work and having good results that they'll allow you to do it and reimburse you for it.
And the most recent sort of development or sort of adding to our program is we've actually enlisted Marion doctors. So there's a doctor, Dr. Arain down at Marion who was trained to do these, but Marion doesn't have the volume to kind of do it. So he's been bringing his cases up here. So we really kind of established a really comprehensive mitral valve program here for the whole Central Coast. It's pretty cool. So as far as heart attacks, all this stuff is great, and we definitely we improve mortality and symptoms and all this. But of all the things that I do, treating a heart attack is still probably the most important because those folks are oftentimes heading towards very imminent death, bad stuff happening, right? So and we can stop that. Stents were developed back in I think. The initial idea was early 80s. They were fought against by a lot of mainstream cardiologists. They didn't think it was going to work, and over the years, that's been proven that folks who are having heart attacks, who have blockages, acute blockages, all of a sudden in their heart arteries, do very well after stents. They do much better than all the medicines they tried in the past. So when someone comes in with chest pain or something that the ER doc thinks is a symptom that could be an issue with the artery, and there's a specific finding on an EKG, something called a ST elevation, that kind of triggers a whole bunch of stuff happening. If they're here, obviously they're going to call the interventional cardiologist. We're going to call out the cath lab team and get that patient to the cath lab. If they're not here, that triggers a phone call to French saying, hey, we've got one coming for you. We do have time limits, so we're supposed to get these arteries open within a certain number of minutes, which we do a good job at. In fact, we do a really good job with the transfers. The other hospitals in the area tend to get their patients to us pretty quickly. But basically what we do, I like to use the wrist artery because it's much easier for the patient afterward. Basically pass a series of very small wires and tubes up to the heart from the wrist artery, inject some contrast dye into those arteries. This is your heart. Those arteries kind of lie on top of the heart. They're kind of like drive lines to the engine. And we take our pictures with the fluoroscopy that Dr. Turner mentioned earlier. With that kind of heart attack, it's going to be pretty obvious. There's going to be an artery that's like completely blocked or like 99% blocked. The other arteries may have plaque buildup in them. We may address those at some point, but we're going to go after the culprit. And we basically, from our catheter, which is sitting right at the beginning of that artery, we pass a little tiny wire. It looks like if anyone plays guitar, the tiniest guitar string you could think of, through that blockage, and we use that as a rail system. So over that wire, we put balloons that expand and come back down, create some space. And the same principle with the stent. The stent sort of collapsed on a balloon. The stent's like a metal scaffold or like a metal tube. So we expand that balloon, it expands the stent, the balloon comes down, the stent is left behind, and it opens up that blockage. And like I said, I mean, we've now known for many years that patients do a lot better once they get reperfusion very quickly, which means restored blood flow.
And I guess just the downside of not opening up that vessel very quickly is kind of long-term.
Yeah, I mean, a lot of things, some people get lucky, but a lot of them don't, and they develop heart failure. They have, we don't really see some of these other complications too much anymore, but weakening of the muscle that may need surgery to fix or to repair. But yeah, there's a lot of, it's kind of an interesting thought because we don't really see a lot of that anymore. During COVID, we thought we were going to see it because our heart attack rate dropped. I mean, those first few months, no one was coming with heart attacks. It was very interesting because we thought these people were just having heart attacks at home. But the data really hasn't borne that out. By then, we would expect to see all the complications of not addressing it. So I don't know what that says about maybe just chilling out for a few months and relaxing. Yeah.
Do patients have more than one stent?
Yeah, a lot of people do get more than one stent. Now, there's different varieties of heart attacks. Like there's the STEMI, which is that one I just mentioned, where it's usually a culprit. Again, if we see other plaque buildup and we think it's significant, we could either fix it at the same time or bring the patient back maybe within the subsequent 45 days. Just depends on kind of the anatomy and the details. But there's other kinds of heart attacks. So there's oftentimes someone is having kind of reached a tipping point, so to speak, where they've got multiple areas of plaque buildup. And there's no one like obvious culprit. There's a lot of them. If they are younger, there's all these things we look at. We obviously enlist the surgeons in that case because if they're younger or diabetic, certain anatomical features, they may need a valve repair replacement on top of it. We're going to direct them towards surgery, and they have bypass surgery. But oftentimes, we'll, if it's one or two or maybe even three, I won't tell them if it's three or four. I kind of keep that on the down low from the surgeons, but we can fix those. Yeah, we could do what's called multi-vessel PCI, and we sometimes stage that. We do a few at one time, and then the next set a few weeks down the road.
How many interventional cardiologists are there now at Coastal?
At Coastal, there are 4. Yeah.
But we've also got Dr. Thompson's actually part of PHC.
Well, I'm including myself in that.
Yeah, and
so,
then we've got Dr. Tway.
Yeah.
So there's 5 that service us here at French.
There's 5 on the call panel as far as who's doing the cath lab procedures. Yeah.
Heart attack's a hot topic.
Could you explain if a stent could fail and what you would do then?
Yeah, so the typical failure for stents is what's called in-stent restenosis. There's some other kinds of failure that are a little more, they're more rare, but that essentially is scar tissue formation that happens where the stent is that re-narrows that vessel over time. That used to happen more often with the first and second generation stents. For a lot of years, stents have a drug coating on them. They're called drug-eluting stents. Some of these medicines are all kind of have their origin in chemo medicines. And they actually prevent scar tissue from forming. That's not perfect. You'll still see, if even the most recent, I think we're now 4th generation stent, you'll still see a certain percentage of folks who develop scar tissue over time, but it's much less. If that happens, we can most of the time put a second stent in, so a stent within a stent, and reopen up that vessel. There's also other reasons for stent failure. Sometimes it's not the right stent. The stent's too small for that artery, or it maybe wasn't long enough. Even 10 years ago, people were just using angiography, which are the pictures I talked about with the fluoroscopy. But we know that an angiogram isn't necessarily the most accurate way to assess the vessel's diameter and maybe the length of the plaque buildup. So what a lot of us have done, and I certainly have been a proponent of this, is what's called IVUS-guided PCI or IVUS-guided stenting. IVUS stands for intravascular ultrasound. It's a catheter that we put down the artery that actually gives us an ultrasound picture of the artery. It's like looking down the barrel of a pipe or something. So we really get an accurate measurement of how big that artery is, and we can put the appropriate size stent, which has less chance of failing down the road.
Could a stent be removed if it were too small or for some other reason?
No, as far as coronary stents, they can't be removed. There are other kinds of stents that other docs put in other parts of the body that can potentially be removed, but not a coronary stent.
Can an artery be too wavy or curvy for a stent?
It can, yeah. Yeah, that sometimes we do see that. And we try to put a stent in and, don't get a great result. We can cause dissections in the wall of the artery. That's pretty rare. The stents are very malleable. They can, when they're being put in the artery, they bend quite a bit, but there are limitations. And so we do see that occasionally. It's rare, but it can happen. I don't know who's next.
Right here.
Okay.
During the process of inserting the stent, you're disturbing the wall. Is there a chance of danger of flaking off part of the plaque, running along?
Yeah, there is. Sometimes that the plaque that we're working on, actually, we're trying to manipulate it. We're trying to modify that plaque before we put a stent in. And there's different techniques of doing that. There's the balloon that kind of smashes things. There's also something called atherectomy, which kind of, in a sense, shaves off part of that plaque. And then the newest thing is actually using a balloon that emits ultrasonic pulses that kind of crack open or crack the plaque, especially the calcified plaque. Some of that, not so much the balloon, but the atherectomy and even the balloon angioplasty, you can get little bits going down into the small little branches. For the most part, they're not, I wouldn't say benign, but they're not going to cause any long-term issue. But sometimes you do, especially in a very fresh plaque rupture, like in a heart attack. We see a lot of that stuff just go into the artery, and we've got to actually suck it out with other catheters. So you kind of have to know what sort of pathology you're treating, and that can help prevent some of that stuff from happening.
I have a question about plaque. And now we have these diagnostic tests that we can take the coronaries for.
Yeah.
And it gives you this story about your plaque. And I'm wondering, is there any way of reducing plaque? Or is it just there forever? And then we're destined to have a stent?
Yeah, I mean,
Destined to have something float around.
As far as it's there, you can't. It's hard to get rid of it. And so a lot of it is, but it doesn't mean that it's the end of the world. It just depends on where it is and how severe it is. And I think a lot of those screening tests or diagnostics, some of them are going to be pretty concerning and something may need to be done. A lot of them for people, I think, are kind of a wake-up call that, hey, this is something that might be happening to me and I need to do everything I can to minimize more of this from happening or not letting it get any worse. And so that a lot of times people start eating better, seeing their doctor more, working with their doctor to be on the right medicines. The idea is to halt the progression or not have the minimal amount of new stuff come. But often what's there is there. And that's the whole game, right? Maybe in the decades to come, the years to come, people will come up with a pill or a treatment, or Quincy's talking about with catheter-based treatments that can actually melt away some of that plaque. And then Dr. Turner and I will be completely out of business.
Hopefully he'll be retired by then.
So we're all developing atherosclerosis basically from the moment you're born until the day you die. It's what is the trajectory, and at what point do you reach that threshold where that's going to affect you, right? So that threshold is going to be different in the left main coronary. It's going to be different in your left common carotid versus your left femoral versus your left tibial, right? There's right-sided vessels too. I just use those as an example. But we're all developing it. And so I would caution you guys, there are they comes out in Reader's Digest and the other, those other periodicals, especially with the AARP, magazines, of these screenings. And they do serve a benefit because a blind squirrel eventually finds a nut, right? I love that saying. I normally use it about myself, okay? However, just be careful, all right? These are conversations best had with your primary care provider at first, not the Reader's Digest full-page advertisement. There's a reason they're advertising to you on a full color page ad. Because a lot of the tests they're doing will then cause a lot of stress for you when you find out that you have a 60% blockage here, a 50% blockage here, and a 30% blockage there. And then you're going to go see Dr. Thompson and he's going to go, but you're just fine. right? Because we're all developing this atherosclerosis. So if you're having symptoms or if other things are happening, your primary care provider and you should be having a conversation about age-appropriate screening and what you should be looking for. And CMS has some really nice standards for when you reach this age, we should at least do a one-time screening for this if you were ever a smoker, or we should, do this. And we're listening to your carotids as your primary care. And we have fallen away from that a little bit. In modern medicine, I think we touch our patients less and we rely on tests a little more. But you'll have to fill out your relationship with your primary care provider. But everything we all do starts first and foremost with a physical exam and a conversation with you. Because just because you have a CT that says you have this plaque somewhere, I don't really care. I want to know how it affects you. That's what matters.
Thank you. So Christy, before we open up for further Q&A, do you have a final question that you want to ask each of the doctors here? And then we can open up for more Q&A before we close.
Well, let's see what you guys want to hear. Here's what's left on the list. We could segue on what you just asked, and they could tell you about, some preventative techniques, but I think everybody's pretty well aware, try to eat healthy. If your doc tells you you should be on a statin, you should probably listen. Don't smoke, get exercise. I mean, we kind of all know what types of things we should be doing. We could ask them where they seek cardiovascular care in the next 5 to 10 years. We could ask them about a day in the life, kind of walk them through what a typical day looks like for them at work. Or if there's a certain moment in their career that they're most proud of. So we'll do a little vote here with raise of hands. So cardiovascular care, where do we see it in the next 5 to 10 years?
Yeah, everything.
We might hold you hostage late and not get to questions. Day in the life. This is looking pretty even. Okay, and then or a specific moment that they're most proud of. Okay, let's do 1 and 3. Okay, cardiovascular in the next 5 to 10 years. Go.
Yeah, I think just further advancements in our minimally invasive technologies. I didn't really get into that, so I'll just recap them really quick for you, some of the hot ones for us. So carotid endarterectomies, surgical cleaning of plaque in order to reduce your risk of stroke in the future if your plaque burden is great enough. We can do that open surgically, still the gold standard, but for high-risk patients or patients with anatomy that would put them at higher risk, we now have what's called TCAR, where we can stent, which the cardiologists have been doing for years very successfully from the groin. But that provides a little bit higher intra-procedure stroke risk than we like to accept, where now we can actually do it with a reversal of flow system, where we actually have the flow coming down that side that we're working on. So any debris comes out, gets caught up in a filter, and then goes back into a vein. So any of that microemboli that we talked about going down to the coronaries can tolerate that microemboli for the most part, as Dr. Thompson said. The brain cannot. Each one of those microemboli is a mini stroke, right? And the smallest little emboli that you guys can see with the naked eye is your arm not working, your leg not working, not being able to speak for the rest of your life. So the meticulous nature that we take in the carotids is to the next level, right? So that's a great upcoming advancement. Aortic aneurysms. So your aorta is too big. We're fixing those and have been fixing those now minimally invasively by deploying these stent graft systems, typically from the femorals. And now we're creeping further and further up where we're able to include all of the visceral arteries and the kidney arteries for a paravisceral and a pararenal aneurysm. And that's something that was really only done at the major academic centers until really the most recent graft was just FDA approved and is not open for wide distribution yet. But we actually can provide that here and have already started providing that to our denizens here in San Luis Obispo County because of our expertise here. So, and then with the peripheral limb salvage work, if you go pretty much anywhere in the nation, the limits of peripheral work end typically at the knee by most providers. There's maybe about 100 of us in the nation with specialty training, most of us learning from the cardiologists who are passionate about limb salvage, who can actually get wires not only down into the calf, but actually get wires, balloons, and devices into the foot in order to do true limb salvage all the way at the level of the foot, which is really the biggest threat to limbs right now is diabetes and the microvascular disease. And so you need a nuanced provider who can actually get all the way to where the root of the problem is nowadays.
Yeah, we're very lucky. I thought when Dr. Turner showed up, I remember asking him, I just figured we had a bunch of healthy folks around here because we weren't seeing any of these patients. And then he showed up and he was putting on case after case. And it was like, well, where did these people come from? And he said, well, we just didn't have anybody taking care of them. They were all getting their extremities amputated. So we're very fortunate to have him here because he's making a huge difference in people's lives and, abilities to just live the way they want to live. So that's pretty special. Yeah. Cardiovascular care in the next 5 to 10 years. What do you guys got?
Whenever I try to predict something, I'm always wrong. But this is going to sound cliche, but there is a lot of work being done with AI, specifically in identifying patients who need treatment. We know that for certain disease processes, even for valves that we do, we probably undertreat. There's a lot of folks out there that have this stuff going on that just hasn't been diagnosed. So AI is going to help us do that. And then, just as an example, there are ideas about making valves, maybe even stents, but tailored for that individual person. Like they can map out the anatomy and know exactly what kind of valve they need. So there's a lot of really cool stuff that sounds, I think, at this point, maybe science fiction, but it will be here before we know it. So
Are you using robotics at all?
I don't use robotics. No, I don't. Yeah.
Robotics, all it implies is it's video camera surgery, so which we've been doing forever. You make a small incision, you put a video camera in a cavity, the belly, the chest, usually the belly or the chest. Those are places where you have some room to work. We've been doing that for many decades now at this point. The robot, instead of using your long tools that you control with your hand, the robot controls those tools and you sit a few feet away from the patient controlling those tools. So it's good for certain things, especially deep down in the pelvis, some of the urology procedures and OBGYN procedures. There may be some advantages for other things like gallbladders and stuff, but it's really not a big leap from what we've been doing in surgery for a long, long time. It's just kind of using a different way of doing it. And different platform.
It's not autonomous in any way. And
Right.
I think people hear robot and they think it is contributing in any sense to the operation, and it is not. It is being controlled directly by the operator who's just sitting at a console instead of sitting on laparoscopes. So instead of me controlling laparoscopic instruments here, I'm controlling them on a console. And really, as Dr. Perry said, the biggest advancement is actually just in where the camera is, and then I'm looking right in the camera here. So that's really the only difference. And it certainly makes your procedure more expensive. It does a really good job with that too.
No, for sure. It's definitely gotten a lot of attention, but I would not call that revolutionary compared to a lot of the things that we talked about today. But it's helpful. It is helpful, especially, again, for things deep in the pelvis. It makes a big difference.
Yeah, I think just for perspective, if you look back 10, 15 years, we've probably been doing TAVR here, those transcatheter aortic valve replacements here at French for about the last 10 years, but they only came out about 15 years ago. So, just the stuff that's come out in my nursing career has been a big change. So I'm sure there's going to be some really neat stuff on the horizon. And we're fortunate to work in a place where I think our administration really supports the growth of this program. And so we will see some of that as we move.
Just a segue on that, not only our local administration, but Dignity Health, I'm not sure we should talk about all the, this may get in the weeds, but so Dignity Health is part of Common Spirit, if you've heard that term. Common Spirit now is the second largest hospital system in the country.
Yeah.
So that gives us a lot of leverage to get devices for a good price, and we have a lot of backup from the national level. So that's certainly helped as well.
Yeah, there's a lot of special, Common Spirit has a bunch of, they have a cardiovascular service line, and then within that, lots of clinical councils that connect our docs to docs on the other side of the country. Dr. Thompson sits on the structural clinical council, so he's head of that, for the TAVR valves and Watchman procedures and the microclips. Dr. Turner's involved right now in selecting what kind of equipment that they want Common Spirit to go to the table and basically work with vendors on better pricing for. So he's saying, hey, this equipment is best suited for our patients, and then Common Spirit can take that and go work with these vendors and be like, look, we have a huge healthcare system, we want good pricing on this stuff, and so that obviously ends up getting passed on to the consumer. So that's a pretty neat thing about our parent company.
I have a question. You're talking about the company.
for you, last question. So when you guys need equipment here in the hospital though, does Common Spirit provide it for you, or does the hospital here locally have to buy it?
Well, that's probably a question for you, but there's budgets obviously, and
Yeah.
we just can't say, hey, give us.
There's a
an extra
lot of
$1 million bucks.
stewardship that comes from Common Spirit, and so there are things out, you want, yeah, you do this.
Yes.
I was gonna say,
Yeah.
so really, the money, I think what the community should know is that everything that's generated at French stays in French's bank account. So really, anything we do, whether it's the cath lab or whatever, we use our funds here, or we use foundation funds. The foundation has been tremendous at being able to help us get state-of-the-art equipment for all of it, for our ORs and everything, because a lot of times, even though we might have a healthy bank account, we also have debt to pay down and things like that on other things. So our money goes towards infrastructure projects and all kinds of other things, but our foundation really helps us to get some of the newest, latest, and greatest instruments that our doctors really want to be able to use. And I think we're very fortunate, because I think for the most part, we try and always get whatever it is that our doctors need to do their job, so.
I've been very pleased with the support. We were talking about the new ways of doing things, the different techniques, and one way I've been able to do that is to get my hands on the equipment.
So to be open, honest, I serve with it before I ask the question, because I know for you guys to get what you need, it doesn't always come from the national organization.
No, a lot of it comes here locally. We've got a couple of new intra-aortic balloon pumps, which are kind of a life-saving device that we put in people after they've had a really bad heart attack, or they're having a hard time after heart surgery and they're in shock. That were funded through the foundation. We have 2 of those IVUS intravascular ultrasound devices. We had 2 systems that were end of life, and the foundation just funded those, and one actually is getting installed next week. And so we're very grateful for the foundation and the support from our local community here. You guys make a huge difference in the care that we're able to offer our patients. All right, last question, and then if you guys have any questions, and we'll wrap it up, because people are probably starting to get hungry. If you could pick one moment in your career that you're most proud of, what would it be?
Yeah, I think it's for the honest answer is I love what I do. And I love taking care of you guys and each individual patient. I mean, I think Christy can attest to this. I work 7 days a week.
Yeah.
And I love my family, and we spend a lot of time together. There's ebbs and flows, and we fill every one of those ebbs that isn't a flow with family time. And so I am so driven by you guys and taking care of the patients. It's really become my hobby. And so where other people are doing their other things, I'm hanging out with my patients, and I'm hanging out in the OR. With that being said, I have a 17-year-old girl and a 14-year-old boy, and for their entire lives, Dad has gone off in the middle of the night, missed dinner, missed the birthday party, missed that because of so-and-so was needing this. And, for them, they always understood and they were always supportive, but it's a little bit of a black box. Dad went off over here, and something happened, and he came back and occasionally told a story. And it wasn't that long ago, I got off early, we were in an ebb, and I picked up the kids from school early. They were finishing track and cross-country practice, whatever, and we went to Home Depot. And we just had pulled into the parking lot, and we got a call from the emergency room, and that there was a ruptured patient at French. So the abdominal aorta had ruptured, and the patient is quickly exsanguinating, bleeding to death in the emergency room. So quickly got in the car, and we all went together. I called my wife. I said, hey, come pick up the kids. It's going to be a moment, unexpected thing at the hospital. And I said, hey, kids, come into the ED with me. Come look at this CAT scan just for fun. And so they came in, and we looked, and we saw, and I was starting to plan it. I called the team in. The OR was already rallying and getting set up. I called ahead of time. I could tell this was real from what the emergency medicine doctor was telling me. And so we were rallying the team. Luckily, the team was still here in-house, so we got going really, really fast. And my kids, what I didn't know is they were standing in the corner of the emergency room. They watched me walk over and talk to the wife of this husband, of this patient who was dying in front of us. And, I told them what we were going to do, and they were going to try and save him. And I said, but let's have a moment, and you say an appropriate goodbye in case I can't bring him back to you. And my kids were like, oh crap. It was real to them for the first time ever. And, you know, 2 kids who are out doing all their thing, my son said, I don't know what to do. All I knew was to pray. I needed to pray for that family because I was really, really scared, and I hoped my dad could save it. And the neatest thing was that they got to stick around, and with the wife's permission, they came with me when I got to tell her that we saved her husband. And so my kids got to see that scared wife say goodbye to her husband, potentially for the last time, as we rushed him off to the OR. And then they got to be a part of those hugs of joy when we saved him. And now, when Dad leaves dinner, it's just that much more real. And those are the moments that keep us going.
And it probably
that
resonates
question's
with all
over.
of us up here because we all love what we do. So go ahead, Dr. Thompson.
No, you can go.
I feel blessed every day to be able to do what I do. As my mentor used to say, this is probably the best job on the planet, and I always agreed with him then, and I agree with him now. I feel very fortunate to be able to do what we do, and a million little moments and ups and downs. But I had a big save early in my career that always stands out whenever I think about what's the biggest moment, or questions like this, or just in my own mind. So it takes a long time to be able to independently operate in somebody's heart. In my case, it was, I guess, 16 years after high school of basically formal education, and the last 8 years of that just working nonstop. Once you're done with medical school and your surgical trainee that I talked about earlier, they have an 80-hour work week rule, but that's hard to. Basically, just live in a hospital for 8 years. That's kind of what I did. And then finish that and go out and can I do this? Am I going to be okay? And so I was working and things were going fine. I was about a year into my practice. This was when I was still in Sacramento, and I was on call. It was a Saturday. I lived in the town of Davis, which was about 15, 20 minutes from the med center, which was in downtown Sacramento. And I got a call that a 9-year-old girl was in the ER. They thought she had a chest full of blood, and could I come help? And I promptly reminded them that I'm not a pediatric heart surgeon, and we had an excellent pediatric heart surgeon on call, and maybe they could get a hold of her. I decided early in my surgical training that I probably wasn't going to be a kid surgeon. I'm a father myself. I love kids, but I don't really like seeing them when they're sick as much. But they had called the pediatric congenital heart surgeon, and she had just started an operation on the north side of town. She just began a procedure she had to do at a different hospital. So they need help. And this wasn't the first time I'd helped out with some of the kids at that hospital. Just by the nature of what I did and the training I had and procedures I did, I helped out with the kids on occasion. So, of course, I got in my car, started making my way down I-80. Of course, there's a bunch of traffic going over the causeway. I'm starting to get a little stressed out. The trainees, all the medical students and residents stuff that work with me, that I'm teaching, are calling me and updating me on what's going on. I'm trying to give instructions. Make my way to the hospital. I think I might have just left my car in the lobby. Ran upstairs. By this point, they'd taken her from the ER right to the operating room. The trauma team was dealing with stuff. Normally, the trauma team, they had an excellent trauma program there. They kind of handle all things on their own. It was rare for them to have to call us. But this was one of those cases they really needed help. They suspected there was a problem with the heart, so they were getting help appropriately. Kind of run upstairs where the OR was. I kind of looked through the little window. There was a little looking glass. Right at that moment, I could tell that all hell had broken loose, for lack of a better term. And what had happened is basically right before I got there, she had completely crashed. They'd already opened her belly to try and figure out what was going on. This is a 9-year-old girl, and at that moment, she just completely crashed. She was about to die. And they knew that she had a bunch of blood in her heart, around her heart, and they quickly, when she crashed, they opened up her chest, which was about the time I got there. When that happened, it was just a free fall of blood, just everything. So right then, I was able to get to the table, I knew what to do. Got my finger on the hole, stopped the bleeding, put her on the heart-lung machine. She had a tear kind of in this part of the heart, called the right atrium. It was right here. It was from a deceleration injury. She was laying down in the back seat of her grandparents' car. They were driving on the freeway, and then there was like a head-on collision or something, and so that the impact of her not being belted in correctly, her body kind of moved forward, and it tore her heart. And the reason she made it that far is because she was a kid, and she was sort of able to tolerate that, until that moment anyway. And so, I just felt, I was able to be there. I was able to stop the bleeding temporarily, get her on the heart-lung machine, divert the blood away from the heart. I had my team there, of course. Fix the injury. The injury actually was pretty complex. It was sitting in a really critical part of the heart, and I think if it hadn't been done with care, she probably wouldn't have survived, and it wouldn't have worked out well with her over time. But I knew how to fix it appropriately, and she did fine, and she did fine, and that was a lot, and it was a lot to take in, and she survived, and she did okay, and then. A few days later, when she was recovering in the ICU, I went by to see her myself, and I took out her drains myself. Again, back then I had a lot of people doing stuff like that for me, but in that case I was doing it all on my own. I took her drains out. Her mom gave me this huge hug and thanked me, and it was a lot. And just thinking back on it, I'd been through so much in the 9 years preceding that, just learning how to take care of people and operate on people and be able to do something like that. And I thought, like, in that moment, even if I never helped one other patient, if I never operated on anybody else, it was like all worth it just to be there for that girl that day. And it always stuck with me.
So as an interventional cardiologist, we see people who are sick quite often, and thankfully we get them back the vast majority of the time, and they go through difficult ICUs and all this stay, but they end up walking out of the hospital. Not to get overly philosophical though, but I think that in a real sense, like the most notable day is today. Like every day has to be, if I don't wake up and choose to do the right thing, then I've kind of just lost the whole purpose. Like, so today I was post-call, I was on call yesterday. We started off with the valve procedure. Everything you do, you can cut corners, you can kind of maybe do it the faster, more expedient way, but we did it the right way. We took our time. I then had a pretty complex stent that I had put in the front artery of someone who was having a heart attack. And again, I could have cut corners and maybe not done the IVUS thing that we talked about before that we did. I was late today here because I was taking extra time in clinic answering questions that people can have a lot of questions because they're just getting to know me, and so I think that today is the most memorable day because I know that I did the good job, right? I didn't cut corners. I didn't get around clinic and just kind of blow off people and get here on time. So I think that if I get to the point where I've realized that I'm doing those things, that it's time to stop. So it's not time to stop yet because I'm still doing it.
So that was unbelievable. I actually cried during the session. This was so touching and amazing. And thank you all so much for what you do every day. Thank you for sharing your knowledge and wisdom and your stories and the technical expertise with us. That was outstanding. I wanted to jump in earlier just to say that yes, the foundation does take 100% of any donor dollars and put it right into the hospital. We don't have an overhead fee. We don't have 5% that goes to salaries and benefits or electricity or anything else. We take 100% of any gift that comes into French Hospital to exactly where you want it to go. And actually, Bob and Debbie Wacker, right before Bob Wacker passed away last year, they said, we need to start up a technology and innovation fund because as quickly as technology advances in all these different fields, we know that it is essential that these physicians have exactly the tools that they need. I mean, who knew that robotic surgery had been around for 3 decades already? I didn't know that. Like, I thought that was the most whiz-bang thing ever, but apparently there's a lot more, and every day there's something more and different and new, and we want to set these guys up for success, right? So I wanted to put that plug in there that the Bob and Debbie Wacker Technology and Innovation Fund does exist, so donors will often select that as the channel for which they want to give. and how they want to make an impact so that these doctors can say, hey, does the foundation have any dollars for this new piece of technology? We really need it. And then we say, yeah, sure enough, we do, because people like in our community care about this, and we happen to have enough resources to pull the money together to get that. So I just wanted to close with a gift for all of you, or not for all of you, for 3 of you. I wish it was for all of you. 3 of you have a blue sticker underneath your chair, and please find us afterwards because we have a gift for you. So if you have a blue sticker, come and find us before you leave. And let's give one more round of applause to all of our physicians. Thanks for coming.